Hey, good morning. This is Dr. Garais, MED220 Professional Procedures, and I hope you can hear me. Of course, taking care of my son, which prompted to why I didn't have um, what do you call that? A Zoom session for today, week 8. And today is September 25th, 2020. So we're a little bit behind on our lectures, but that's all right. I'm going to go over EKG, what's important in the EKG, and also a review of what we did in the laboratory. And then I'm going to do phlebotomy, and hopefully maybe later on this weekend I'll get to urinalysis. But we're good because that's why I reserved week 9 for not only a review, and you could see there's a final version. I won't make that available until the end of week 9, beginning of week 10. All right. So, and again, the protocol will stand. You just email me the answers, okay? And the final written will be. Please don't do this one. The one I loaded is an old one, and again, ignore the dates. I will be updating the dates, of course, but it will be based on EKG, phlebotomy, and urinalysis. 40 to 50 items, multiple choice. So let's go over what's really important. First, the EKG procedure. Let's look at that. You must know, of course, the EKG procedure. What do you do first? And remember, why do you turn the EKG on first? It's because for telemetry to catch up. Most EKG machines now are connected to the web, connected to the internet, and the second you type in any patient identifier, and remember your 2 patient identifiers. For the record, it's your social security, last 4 digits of your social security, and or your date of birth. Hand washing now is always required because of the COVID for even non-invasive invasive procedures. In the past, you might see a video of mine that says you can use hand sanitizers for non-invasive procedures such as EKG, but nowadays you can't. It's hand washing for everything, glove up for everything. Okay, this robe is only from the waist up. Remember, difficulty breathing or the patient cannot tolerate lying flat, usually respiratory or maybe geriatric patient, right? Or a patient in pain states, use Fowler's or semi-Fowler's position, adjusting the pillows under the head and the knees for comfort if needed, or you move the bed. Now, another key thing is you got to tell the patient to breathe shallow, not normally, because if they start breathing like deep breathing, then that's going to become a problem. Hey, Edison, I'm doing a lecture. Can you tone it down a little? All right. Chest hair, remember, we do not cut anything. You just take your fingers, move it out of the way, and of course clean the area with 70% isopropyl alcohol. Shaving is not recommended. This is not a surgical nor invasive procedure. Know where to put the electrodes. I'll be going over the leads shortly. But remember, in the fatty parts. So the official parts for your limb leads, for your arms, is the lateral deltoid, anterior bicep, or the fatty part of your forearm, or volar surface of your arm, around the area of your brachioradialis. If you don't know what I just said, look up your anatomy and physiology. You should know. Another place for the limb leads is also the lateral or medial thigh and the belly of your gastrocnemius, also known as your calf. Another common place as well, especially if you don't want the patient to pull up their socks or take off their shoes and whatnot, you can put your right and left foot leads on the lower portion of both the right and left abdomen, respectively. Remember which tabs go up, which tabs go down, depending on the placement of the hub, right? Know the exact locations of your precordial leads. So I'll ask you, where is exactly V3? Where is exactly V2? Where is exactly V5? What else needs to be important? 25 millimeters per second is the standard paper trace. That's a common question. I won't really ask too much about the boxes. That's in your EKG class. But I will definitely ask about what is normal. Okay? And we're going to go over that momentarily. Next. Got to know a little bit of your cardiac anatomy, especially the one thing that you really need to know is this stuff, man, it's a rehash of the lecture, not some nice things to know. But the video conduction of the heart, okay? Look it up on YouTube. You know what? As I have you here, I might as well put it in here. And you go on YouTube and video conduction of the heart. And there's this really nice, and here it is. Watch this video. I'm gonna put the link up. It's a wrap. I'm gonna put the link up because it shows you the parts of the conductive system of the heart, which is the pacemaker is the sinoatrial node, the brakes or the pause or the gateway is the AV node, and then all the other processes, all the other steps to the conduction system of the heart. So let's add this. Turn editing on. And let's put it here with the EKG stuff. I want to add a video or a link. It's better. I want to add a URL. Add it. Hey! Heart. Here's the URL. And know the parts of the conduction system of the heart. SA node, AV node, bundle of His, left and right bundle branches, and Purkinje fibers. And that's the order. And then 2, know the AV node is the pacemaker. Know the, not AV node, my bad. SA node, pacemaker. Know the AV node is the gatekeeper. Or from my previous lecture, the brakes of the heart. Slows it down because the natural pacemaker of the heart is around 100 beats per minute, and you know that's really fast. And you need time for the atria to fill, so the AV node is the gatekeeper. And also the relative locations where all these are. Of course, know what all the EKG waves mean. For example, P wave equals atrial depolarization. That means the atria are going to be doing work. QRS complex, ventricular depolarization, and the T wave, that's ventricular repolarization or resting or recharging of the heart. So let's save that and watch that video. It's really nice, and if you had me for anatomy and physiology, you should already know that. Okay? Lead placement, really important. Yes, look at that. Now, it's only fourth and fifth intercostal space, right? But that's 1 and 2. That's right sternal border, fourth intercostal space, left sternal border. Add that to your notes. Now V3 is simply between V2 and V4. V4, V5, V6 are all fifth intercostal space, but V4 is midclavicular line, V5 is anterior axillary line, and V6 is mid-axillary line. I could draw you a picture, A, B, C, D, E, F, G. I could just ask you straight up what's V6. Know also your limb leads. Know that your bipolar limb leads are your leads 1, 2, and 3, written in Roman numerals, and it goes from negative to positive. So it goes from, lead 1 is from your right arm to left arm, lead 2 is from your right arm to left leg, lead 3 is from your left arm to left leg, and your right leg is always the ground. Now your augmented leads are your unipolar leads, and that's your augmented VF. That means it's got to go from your heart or the middle of your chest to your foot. Which foot? Left foot. The right foot, remember, doesn't participate in any of these triangles, also known as Einthoven's triangles. AVL is what? Going to left arm, from the middle of your body to left arm. And AVR is middle of your body going to right arm. And that's why they call it unipolar leads and augmented leads. The electricity for this isn't very big, and it has to be augmented, hence the name augmented. And it's unipolar, it only goes one direction, right? From the middle of your body outward, either to your foot, to your left arm, and to your right arm. Okay, and those are your 6 limb leads, and these are your 6 precordial leads, and they have the V in front of it. I remember that the V looks like some dude's chest if he's really ripped or whatever, right? And that's how I remember it. And remember, whatever silly way you can remember something, that's the thing, that's the way you should go. Okay? And those are your lead placements, and along with the hints that I told you about how to place your limb leads. Now this bad boy right here, oh, I wish I could take this and look at it sideways. Now, 71, just like the other day. This was taken a while ago. But let's see if we can try to take this and turn it right side up. How do I do this? So I'm like this. What's going on? No, this is no bueno. What's going on? Oh, here it is. So I can take this and let's make the layout landscape. Maybe this will do it. No. How do I? Don't I have an art something? No, I don't have any art thing that I could use. But let me just go over so that you can go over the one that you took in class. Let me go back to this. So let's look. Let me find NSR and then talk about it right here. Here's a classic. And let's put this in Microsoft Word so we can see it a little bit easier. Okay. Now, how do you know something's normal? NSR, right? Normal sinus rhythm. The word sinus means that it's what goes up must come down, and it's a sine wave means electrical normalcy. It's the best way to put it. Now, if we look here, leads 1, 2, 3, except for this 3, leads 1, 2, and 3 typically should be upright. Is this thing even normal? All right, that's a signal that I might have to pause this video shortly. How about this one? This is better. So let me copy this image and let's look at it. So let's look at this. Now remember those little towers that they cut off here? You can see them here. Okay. Those little towers. Now those are calibration towers. They all have to be equal. Another thing that you have to notice is that in leads 1, 2, and 3, the QRS complex has to be upright. AVR, since it's pointing away from the heart, the QRS complex should be upside down. Another thing you'll notice is your long lead 2, the distance from this R wave and this R wave should be pretty much even. And you can see here, oops, it isn't. See how it's a little bit longer here, a little bit shorter here? Looks like you got a skip beat, right? And the last thing you should be looking at is the QRS complex here should getting bigger, 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 and then get a little smaller in V6. And that's called your progression of your precordial leads. If you have all of these things that I just mentioned, and the rate is regular, and it's between 60 to 100 beats per minute, then you have NSR, okay? Don't rely on the telemetry or the little comments that the EKG machine makes, because can the EKG machine be wrong, right? Yes, they can be. And that's why we need a good tech to make sure that things are right. All right, so on that note, I'm gonna pause this because, those are a good review over what we went over in lab and also what we saw in lab and what you should already know from your EKG procedure. You are responsible for all of this for the final exam. And again, the final exam will be made available end of week 9, and it'll be take home. Okay? All right, this is Dr. Garais signing off.